3 weeks ago, a crucial piece of medical research emerged. And honestly, it's the kind of finding that will make many established doctors furious, because it proves that the very foundation of how we treat high blood pressure has been wrong for decades, especially for our older population. For as long as I can remember practicing medicine, and certainly for the last 20 years of standard cardiology advice, the mantra has always been the same. Your blood pressure goal is 120/80. That's the magic number. It's perfect, it's optimal. The lower you can push it, the better you're protecting your heart and brain, right? Wrong. Absolutely wrong. If you are over the age of 75. This new groundbreaking research followed 15,000 seniors over the age of 75 very closely, and what they discovered was shocking and directly contradicts everything we've been taught. They found that seniors who actually reached that 120/80 goal had significantly higher rates of serious falls, catastrophic fractures, and most importantly, higher rates of death than those seniors who maintained a higher pressure. I want to get to know you better. Write your name and which city you are watching from in the comments below. I'm Dr. Barbara O'Neill, and I watched this principle play out in real time with a patient I'll call Margaret. She was 78, sharp, active, and fully independent, living alone. 6 months after her doctor, following standard guidelines, finally got her blood pressure down to that coveted perfect number, she died. Margaret didn't die from a massive stroke or a sudden heart attack. She died because her blood pressure was too low. She fell, she fractured her hip, and once that happened, she never recovered. The cascade of decline, immobility, surgical trauma, infection, and pneumonia was initiated not by high blood pressure, but by pressure that was aggressively pushed below what her aging body needed to stay upright and perfused. By the end of this discussion, you'll understand the specific personalized blood pressure range that is actually safe for your age, a range that could literally save your life or the life of someone you love. But I won't give you that exact target number yet. If I reveal it right now, some of you will simply write it down and leave, and that would be a huge mistake. You need the full context. You need to understand why this number is different for seniors, and you need to see exactly what happens physiologically when blood pressure drops too low in older adults. You need the complete picture before you can safely discuss the exact evidence-based range your doctor should actually be targeting. Margaret's journey is the perfect case study in how rigid adherence to generic guidelines can fail the individual patient. When she first came to her primary care physician, her blood pressure readings were consistently around 152/88. According to every textbook published before 2020, this was high. Her physician was determined to fix it. He started her on a mild diuretic, which is a common safe starting point. A few months later, the pressure was down to 140/85, but the doctor wasn't satisfied. He told her sternly that she was risking a stroke and a heart attack every day she didn't hit 120/80. His intentions were good, his adherence to outdated dogma was the problem. So he added a second medication, a low-dose ACE inhibitor. This brought her down further to 130/80. At this point, Margaret started complaining about a very specific and critical symptom. She mentioned feeling lightheaded sometimes, especially when she got out of bed too quickly in the morning, or when she stood up from reading a book in her easy chair. She was experiencing classic symptoms of impending disaster, a condition known as orthostatic hypertension, a dangerous medication-induced drop in pressure upon standing. But what did her doctor say? He dismissed it. That's just normal aging, Margaret. Everyone gets a little dizzy sometimes. Your blood pressure looks great on paper. Keep taking your meds. This dismissal of critical patient feedback because the numbers looked good is exactly where the system fails. Older adults. The final fatal step came when her doctor introduced a third drug, a calcium channel blocker, to aggressively push her below 130. They succeeded. When Margaret had her final checkup, Her systolic pressure was 122, and her diastolic was 78. Her doctor congratulated her profusely on achieving the perfect number. Margaret, however, felt terrible. She was constantly fatigued, slightly unsteady, and terrified of walking up and down stairs. She mentioned her dizziness again, and again it was disregarded because the metrics on the screen were ideal. This is the core tragedy. Medical professionals often focus entirely on the number they read while the patient is sitting down, ignoring the functional reality of the patient's life and the extreme drops that happen when gravity takes effect. The fall happened at 3 morning hours. Margaret woke up needing to use the restroom. She swung her legs out of bed, stood up, and the world went black as blood drained from her brain. When the paramedics arrived and stabilized her, they took a set of vital signs that should shock every single doctor clinging to the 120/80 rule. When Margaret was lying down, her blood pressure was 118/74, still perfect. But when she was helped to sit up and stand, her pressure plummeted to a catastrophic 82/54. Her brain momentarily starved of oxygenated blood, leading to a syncopal episode. She lost consciousness immediately, impacting the floor, resulting in a severe complex hip fracture that required major surgery. For an 80-year-old, a fall often marks the beginning of the end. Margaret never regained her mobility. She struggled with pain and became almost entirely immobile, and within a few months, she developed aspiration pneumonia due to prolonged bed rest. Her life ended prematurely, not due to the disease her doctor feared, but due to the treatment he insisted upon. We must stop treating the symptom, the number, and start treating the entire aging patient. To do that, we need to understand the 4 critical non-negotiable differences between a 40-year-old's circulatory system and an 80-year-old's. These differences explain why Margaret was doomed the minute her doctor chose 120/80 as the target. The first difference involves something called arterial stiffness, or arteriosclerosis. Your arteries harden naturally with age. This single change in the vessel wall is why dropping the pressure too low means literally starving your brain against gravity. When you understand how the stiffness of your arteries demands higher baseline pressure to achieve adequate blood flow, you will finally realize why that perfect low number is actively risking a fall every time you stand up. If you are taking blood pressure medication right now, and you sometimes feel dizzy when you get out of bed, this next physiological principle is the key that could save your life. That physiological principle centers on the fact that your arteries are no longer flexible rubber bands. They are more like rigid pipes. Think about your circulation system. To push blood up against gravity from your heart through your neck and into your brain, it takes a certain amount of hydraulic pressure. In a younger elastic artery, when the heart pumps, the vessel wall stretches and helps carry that momentum. But as stiffness sets in, the artery cannot stretch. To maintain the same level of flow and keep the brain fed, you naturally require a higher baseline pressure. When doctors insist on dropping that baseline pressure too low, they are essentially fighting the physics of a rigid system. They are starving the brain of the pressure needed to overcome gravity every time you stand up, which is exactly why Margaret felt unsteady and why her brain momentarily lost consciousness when she got out of bed that night. That arterial stiffness works in conjunction with the second major change, decreased baroreceptor sensitivity. Your baroreceptors are marvelous little pressure sensors located primarily in your carotid arteries and aorta. When you stand up quickly, blood pools immediately in your legs due to gravity, and blood pressure drops instantly. In a young person, these baroreceptors recognize that drop within milliseconds and send an immediate, high-priority signal to the heart to increase its rate, and to the vessels to constrict and squeeze the remaining blood back up. This compensation prevents fainting. But in an older adult, these sensors are sluggish, like a slow internet connection. The signal is delayed, sometimes by several seconds, and the compensatory response is weak. If you combine slow sensors with rigid arteries that require high baseline pressure, and then you lower that baseline pressure with medication, you have created the perfect recipe for a catastrophic syncopal episode. The body simply cannot compensate quickly enough, and the blood pressure drops straight through the floor, resulting in what we call orthostatic hypotension. Now, let's layer in the third challenge: altered medication sensitivity. We assume that medications work the same in every adult, but an 80-year-old's body processes drugs far differently than a 40-year-old's. As we age, our liver and kidney function naturally decrease, even if they remain within the normal lab ranges. This reduced function means that many blood pressure medications, which rely on the liver and kidneys for clearance, stay active in the bloodstream much longer than they should. A dose that was fine last month might slowly accumulate over time, turning into an effective overdose that aggressively lowers the blood pressure day after day, week after week. This insidious accumulation explains why Margaret's blood pressure continued to drift lower and lower, forcing her doctor to check her metrics more often, but never truly diagnosing the root cause. The medication was staying in her system too long and causing those extreme drops when she wasn't sitting perfectly still in the clinic chair. The fourth and perhaps most crucial difference is the change in the risk profile. When we treat a 40-year-old's high blood pressure, we are performing a long-term investment. We are reducing the chance of them having a heart attack or stroke 20 or 30 years in the future. Their immediate risk of harm from slightly low pressure is minimal. But for an 80-year-old, the equation flips entirely. The immediate overriding risk is falling. The small, theoretical, long-term cardiovascular benefit of achieving that perfect 120/80 number is completely dwarfed by the massive immediate risk of a fall, a broken hip, major surgery, and the subsequent rapid decline in mobility and mortality. If Margaret's doctor had focused on maintaining her independence and avoiding falls, he would have realized that a blood pressure slightly higher, say 138/85, would have been much safer for her functional quality of life than the medically prescribed perfection that ultimately took her life. These four physiological realities, arterial stiffness, delayed baroreceptors, altered drug processing, and an immediate fall risk, are why the old rules no longer apply. They explain why recent definitive research has entirely contradicted decades of accepted medical guidelines, and why we must change the targets immediately. And this is where the real revelation begins, the finding that completely overturns Margaret's death, and the unnecessary suffering of countless other seniors. For decades, the medical community operated on the assumption that if 120/80 was the gold standard for a 40-year-old, it must be the aspirational goal for everyone else. They believed that aggressively driving that number down in older adults would provide the maximum possible protection against stroke and heart attack. But when major definitive research studies finally isolated and analyzed the outcomes specifically for adults over the age of 75, they uncovered a truth that was frankly shocking to the established medical order. They discovered that the individuals who had the absolute lowest rates of death and serious complications were not those who achieved the medically ideal 120/80 target. Instead, the elderly participants who experienced the best health outcomes, those who lived longer and retained their independence, were those whose systolic blood pressure hovered safely in the range of 130 to 140 mmHg. Let that sink in. Aiming for a number that doctors previously called pre-hypertension actually led to superior survival rates. This data directly contradicted decades of standard practice. The reason this range is protective stems from the physiological challenges we just discussed. Remember the arterial stiffness. The 130 to 140 systolic pressure range provides the necessary perfusion pressure. Think of it like a gardener trying to water a high flower bed with a hose that has rigid old tubing. You need a slightly higher pressure from the faucet to push the water up against gravity and stiffness, to ensure the highest blooms the brain cells get properly watered. If the pressure drops to 120 or lower, especially when that 80-year-old stands up, the flow to the brain drops off the cliff, triggering dizziness, imbalance, and the catastrophic fall risk. For an 80-year-old like Margaret, her body needed that extra systolic cushion. If her doctor had allowed her pressure to safely reside at 138/85, her slow baroreceptors would have had more time to react, and even a temporary pressure dip from standing wouldn't have pushed her into the dangerous zone of losing consciousness. Her brain would have remained adequately perfused, and she would have retained the stable balance necessary to walk through her house at 3 a.m. So the research is crystal clear. Treating an 80-year-old to the same blood pressure goal as a 40-year-old is medically negligent, even if the intention is good. We must shift the target, not based on an arbitrary national guideline, but based on individual physiology and the overriding goal of maintaining functional independence. Achieving the perfect number is useless if the process of getting there leads to a broken hip. The shift in thinking requires us to adopt personalized goals based on age, frailty, and mobility, not just a number on a chart. This means we have to move past the old mantra and establish new, safer guidelines that actively protect our mobility. We now have specific, evidence-based systolic targets that are designed to minimize falls while still managing long-term cardiovascular risk. For generally healthy adults aged 65 to 75, the safest range is now considered 130 to 140 systolic. Once we move into the 75 to 85 age bracket, especially if there is any sign of reduced kidney function or cognitive changes, that optimal target moves slightly higher, ideally staying between 135 and 145. And for our most frail, or those over 85, a systolic pressure between 140 and 150 is often the most protective choice, ensuring the brain stays fed and preventing the orthostatic drops that lead to disaster. But the crucial question for you is, how do you know if your current blood pressure target is too low? And what specific steps can you take right now to protect yourself or your loved one? The answer lies in a simple, overlooked test you can easily perform at home. This test is formally known as checking for orthostatic hypotension, and it's the single most powerful piece of data you can bring to your next doctor's appointment. Here is how you perform it correctly. First, lie down flat on a bed or couch and relax for 5 full minutes. Keep your blood pressure monitor ready. After 5 minutes, take your blood pressure while still lying down. This is your baseline number. Now immediately stand up. The moment you are standing, within the first 60 seconds, take your blood pressure again. You must take it quickly because the body tries to compensate rapidly. What we are looking for is a significant drop between the lying number and the standing number. If your standing systolic pressure drops by 20 points or more, compared to your lying pressure, say from 135 lying down to 115 standing up, or if your diastolic pressure drops by 10 points or more, you have confirmed orthostatic hypotension. This means that when you stand, blood is pooling too fast in your legs, and your heart and rigid arteries cannot compensate quickly enough to feed your brain. You have concrete, irrefutable evidence that your current blood pressure medication regimen is over-treating you and actively placing you at risk for a fall, a fracture, or a blackout. This knowledge shifts the dynamic entirely. If you present this data to your physician, you move the discussion from abstract guidelines to personalized physiology. Instead of arguing about why your target should be 140/90, because the guidelines say so, you are showing them that your current level of 128/78 causes dizziness and a dangerous pressure drop when you stand. This evidence demands an adjustment, likely a reduction in medication dosage or a conscious shift to a higher, safer target pressure. Remember the story of Thomas, a spry 82-year-old gentleman who was constantly tired, dizzy, and felt too wobbly to enjoy his daily walk. His doctor was proud that Thomas's blood pressure was a perfect 28/76. When Thomas's cardiologist finally allowed his systolic pressure to rise just 8 points, moving him to a relaxed 136/80, he felt like a new man. His dizziness vanished, his energy returned, and he started walking 3 miles a day again. The slightly higher pressure gave his baroreceptors the necessary cushion and margin of error, ensuring proper brain perfusion when he moved. Thomas traded an arbitrary perfect number for a significant increase in his quality of life and functional independence. Your goal is not to achieve the number 120. Your goal is to maximize your function and minimize your risk of fracture, hospitalization, and decline. For older adults, the biggest risk is the fall, and the primary preventable cause of falls is overly aggressive blood pressure management. We must advocate for personalized targets using the 130 to 140 range as our foundation for healthy seniors, and always check for orthostatic hypotension. This tailored approach, based on function and frailty, is the future of senior health and what we strive to share with you here at Much More Health. Now, I want to know if you liked the video. Leave a rating from 0 to 10 in the comments, so we know if we are on the right track.